Mikey V.
What's going on?
Man, you work some cardiac arrest, right?
Yes, sir.
Where do you work them? You work them on scene, or do you go en route to the hospital for the magic stuff? What do you do?
My first question would be, what does the science say about that?
What does the science? Well, this is a science-based podcast. We will be right back, and we're going to talk about the science.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff.Jarvis.
Howdy, y'all. This is Dr. Jeff.Jarvis, and I have a special guest, Mikey V.
It's so good to be back on the show. My last one.
Absolutely.
Austin,
at my house.
Austin, at your house. Yes,
This
sir.
is true.
Yep.
We're not in Austin anymore.
We are not in Austin. We're not in Oregon.
Nope. It's a shame.
Where must we be?
Maybe Nevada, somewhere in between.
Or Nevada. Yeah. Yeah. It is sort of in between, isn't it?
It is. Where are we? We got some stuff going on behind us.
There's this place is a buzz right now. We are setting
buzz.
up for Fast 22 here in beautiful Las Vegas, Planet Hollywood Hotel. And man, it's been a busy couple of days getting ready.
This is exciting stuff. By the time you listen to this, Fast 22 is going to be gone.
Yeah.
History in the books. Back together again, but in the books. But the good news is I can go ahead and tell you now, even though the show hadn't happened yet. We've done some rehearsals.
Indeed.
They've been good. I'm excited. This is a great show.
Yeah.
The concept, essentially, we're talking TED Talks, great interactivity between the faculty and the participants.
Yep.
We're basically all participants here. Wonderful show. If you want to get the FAST experience, where are we going to be next year?
We're going to be right here, May 9th, 10th, and 11th, 2023. Same place.
Yep.
It's going to be awesome.
Yeah. So make sure you write that down. May what?
9, 10, and 11.
2023. Put it on your calendars now. Hope to see you. It's going to be wonderful stuff. Well, Mikey, let's get into it. I got two papers I want to talk about with cardiac arrest. The big question, should we stay and play or should we load and go?
Yeah.
Two questions here. So let's take a look at one. The paper that we're going to talk about first is by Grunau and colleagues. This is the Association of Intra-arrest Transport versus Continued On-Scene Resuscitation with Survival to Hospital Discharge among Patients with Out-of-Hospital Cardiac Arrest. This was in JAMA 2020. This really helps inform this discussion. So to give you an idea of what this was, I think you may have been in this study. This was a secondary analysis of the ROC epistry. This is a registry where all of the ROC systems combined their data on cardiac arrest, and even though the studies that they were collecting the data for were not about this particular question, great data that had been validated up front, we can go back and look at this and answer different questions.
Yeah, and I think, not to interrupt you, but I think when we've talked about the fundamental things of research, right, using this existing data as much as you can for as many things as you can, even though maybe that wasn't your primary focus initially, is like we have a responsibility to do that.
Absolutely.
Yeah.
So we enrolled patients in this trial. All of these trials were using EFIC, exception from informed consent. And we have an obligation as researchers, even though I wasn't part of this study, as researchers we have an obligation to learn as much as we can from the risk that those patients took on.
Yeah.
So I think that's a great point. Well, so the fundamental question that we had here is we took a look at all of those patients. These were adult patients, 18 or above, non-traumatic cardiac arrest. And what we were looking at is we took all of those patients and we broke them up into two groups. Those that had intra-arrest transport, so basically we went to the hospital, CPR in progress, versus those that had on-scene resuscitation. They worked to completion, meaning either field term or ROSC.
Yep.
All right, so we have two groups. Now, they're going to be a bit different, right?
Of course they are.
Because maybe there was a reason we had resuscitation and why we went. So they did some analysis on this, and what they did some adjusting to try to control for these different factors. Things like the age of the patient, the initial rhythm, whether there's bystander CPR, all the normal Utstein things. And then they said, what is the difference in survival to discharge between intra-arrest transport, load and go,
Yep.
versus on scene? All right. Then they asked the same thing with functional survival. Bottom line is, for those patients, there were about 9,500 that had intra-arrest transport versus 18,000 that had on-scene resuscitation. Survival to hospital discharge, and remember, this is all comers, not just VFib.
Right.
This includes granny with the asystole and the sepsis.
Yeah.
All comers, survival was 4% if you had rapid transport versus 8.5% if you worked them on scene. That's a difference of 4.5% and an adjusted odds ratio of 0.48, meaning if you transported with CPR in progress, you had a 52% reduction in the odds of survival to hospital discharge. And if you look at functional survival, well, the odds there, the odds ratio, again, adjusted was 0.60, meaning a 40% reduction in the odds of neurologically intact survival. Now, the cool thing is, because these were multiple systems,
Yep.
they include a plot that says for each system, what was their percentage of patients that had inter-arrest transport, and those ranged anywhere from 0%, like they don't do it at all the way up to above 60%, meaning they do it all the time.
Wow.
And they could also calculate what that system's overall survival was. So there's this beautiful plot I'm going to put up on the screen. It's figure 2. And what you see is those agencies that had the lowest proportion of intra-arrest transports. Another way of saying that is they worked the majority of their codes on scene, had the highest survival. So Site A, they contributed 4,800 cardiac arrest. And of course, we have no idea who Site A
Right.
is. But 4,800 cardiac arrest, almost no intra-arrest transport, and just under 20% survival. Overall, that's amazing.
Yeah.
On the other hand, you have J. Poor J.
No one wants to be Jay.
Nobody wants to be J. 873 arrest they contributed. Intra-arrest transport, over 60%, and the overall survival was under 5%. This plot has a very clear linear association. The more you transport CPR in progress, the worse your patients do.
Yeah.
So if you value a 40% reduction in the odds of neurologically intact survival, stay in play.
Yeah. Well, so how does this jive with my system? We're a stay and play. Stay and play. Are we allowed to say that still? We work our arrests where we find them.
I like stay in play. Stay in play works.
But there's a couple of times
No?
where we're going to go.
Okay. All
Right.
right.
So
What kind of times?
pregnancy, 32 weeks or greater, right?
Oh.
We're going to start Lucas and we're going to go. But the one thing
I want to
yeah.
talk to you about that.
Okay, all right.
I want to talk to you about that.
Okay.
All pregnant women, regardless of how long they've been down? Let me give you a case.
Yeah.
Completely hypothetical.
Okay. Of course.
27-year-old female, history of polysubstance abuse, found down, cardiac arrest,
Initial rhythm?
asystole on our arrival. Downtime, we're thinking 20 to 30 minutes.
Yee.
We work them because,
Okay.
she's pregnant. Push the fundus off to the side, get the ultrasound out, right on the belly,
Okay.
no fetal cardiac motion. Would you transport that patient? And if so, are you transporting for the mother or the fetus? Oh, and by the way, she was 7 months pregnant.
Yeah, so completely hypothetical. So
Completely hypothetical.
I feel like we missed the boat on this one. I don't know that I would even continue to. I mean, we might continue to work it a little bit on scene. I definitely don't see an intra-arrest transport this time. I guess. Yeah, I mean, I don't think. Yeah, I don't.
Yeah, it turns out no fetal motion, no maternal cardiac motion.
Yeah.
Asystole in title is like 5.
Yeah.
The problem there is we needed to have dealt with that substance abuse problem long before we got into this situation.
Yeah.
But when you said transport pregnancies, you're talking about like arrest right in front of you.
Arrest right in front of
Yeah.
you, a traumatic arrest, whatever that might be. Yeah, for sure.
Again. Any other circumstances?
Yeah, I was going to say, well, and we're not quite there yet in our system, but I know some systems are transporting early for patients to go to ECMO.
Yeah, so that's the big question,
I mean,
right?
I feel like we're close.
Yeah,
But we're just not there.
close to being ready.
Yeah.
So a lot of people, particularly those in ECMO centers, they say, you damn paramedics need to quit screwing around.
Mm-hmm.
Oops, Siri is getting in on this. They are saying, not,
Yeah.
a certain auto thing here.
Right.
They are saying that you just need to bring all of your patients, put them on a Lucas, throw them in the back of the ambulance, rush them to us. We're going to save everybody with ECMO.
That seems to be contradictory to what we just learned, but I mean,
does.
I know Lucas
It
is
does.
maybe it's a little bit different. I don't.
Yeah,
know
I
that-
don't think so.
I don't know that may be true.
You know, the
but
linked trial compared no difference
You're
in
right.
survival.
You're right.
Maybe we weren't using it right. Always an issue.
How long did it take to put on? There could be a bajillion things. I don't
Bingo.
know.
But I think in this issue, what we're talking about is we need to get them to ECMO, and Lucas might provide a safe way to do that and a safe way to continue compressions while you're cannulating
Yeah.
them. Well, it turns out that's a really good question. If we're going to do this, who should we do it for? How do we select the patients? Great question. We have a paper hot off the presses. Let's talk about it.
I love it.
This is by a couple of quite a few actually, Czech authors. The title of the paper is Effective Intra-arrest Transport, Extracorporeal Cardiopulmonary Resuscitation, and Immediate Invasive Assessment and Treatment of Functional Neurologic Outcome in Refractory Out-of-Hospital Cardiac Arrest, a randomized control trial.
Say that 3 times fast.
I don't think I will. What we're talking about here, this is not field ECMO, it's in-hospital ECMO, but we are rapidly transporting patients to the hospital, cannulating, and then going to cath. So this was published in JAMA 2022, hot off the presses again. Let's talk about this, shall we?
Yep.
So randomized control trial, they randomized patients with pre-hospital cardiac arrest who had had at least 5 minutes of ACLS. So they've had some defibrillations if
Okay.
defibrillations were needed. They've had that life-saving epinephrine on board.
Oh, yes.
They've had something done with the airway, and now they get randomized.
Okay.
All right. So this was a single study that was done in Prague. Beautiful, beautiful Prague.
Yeah.
Love me some Prague. Gorgeous city. And they did it looking at every patient who was coming to this center. And again, they randomized them once they had had 5 minutes of ACLS.
Can
and
I
they-
ask you how they did the randomization?
Absolutely. So
I'm curious.
they have a single center dispatch system. And when they dispatched cardiac arrest, they notified the ECMO team.
Okay.
And they also opened up a web-based app that did the allocation.
Oh, okay.
And then they called just over the radio and said Group A or Group B. So
Okay.
that's how they did it.
Okay, cool.
I was actually fascinated because
Yeah.
they pre-alerted the ECMO team at dispatch.
Interesting. Okay, cool.
Not sure how well that would fly in the U.S.
Yeah.
I'm not sure how well that would fly in Prague if you're not in part of a study.
Right, doing a study.
So let's talk about the intervention.
Yeah.
They did 5 minutes, then attached to Lucas,
Okay.
went en route, went directly, bypassed the emergency department, went directly to the cath lab where they were ready. They cannulated, put them on ECMO, then took them off of the Lucas, and they maintained ECMO long enough for them to get PCI and stenting if that was appropriate.
Okay.
Then if they were in the control arm, they would continue ACLS in the field until they would either decide to transport for whatever reason or do the field termination.
Okay.
So treatment after that was just standard of care. So targeted temperature management, all of the other things identical.
Okay.
So a couple things that we found. Number one, they had 4,300 cardiac arrests,
Wow.
and they only enrolled 264. So we're talking a small minority.
Wow.
So what did the patients need to be? So they were
Yeah.
adults. They were greater than 18 but less than 65.
Okay. There's one possibility. Yeah.
It had to be a witnessed arrest.
Okay.
So we're already talking a small group.
Yeah.
Then they were excluded if they got ROSC early. Makes sense.
Okay, yeah.
They were excluded if they determined there was a DNR or obvious death. And then this was something that I think is really important. The folks enrolling them, the treating physicians, could do crossover and say, you know what, this patient would really benefit from ECMO.
Okay.
Therefore, ethically, we're going to cross them over.
Okay.
They're still counted in an intention to treat analysis. They would also do that where if they got randomized to the ECMO group, and this was obviously futile, they could bail out.
Okay.
All right, so
I like
that
sounds very well constructed. I like
well,
it.
that thing right there is an obvious bias because it can
For sure.
it can bias the results to favor ECMO.
Indeed.
Makes sense, because if you say, I know we got randomized to ECMO, but this patient isn't going to survive, so we're not going to do it, that would make the ECMO group look better because you're narrowing down
You're right.
the denominator. If you got randomized to not ECMO, and you're like, oh, this is 18-year-old
This
witness
is an
defib
ECMO
arrest,
guy.
this is ECMO,
Yeah.
and you do ECMO on them, that can, again, bias it toward ECMO.
Yeah.
A couple of other things about this trial. In both groups, 60% of these patients were in VFib on arrival.
Wow.
Initial EMS rhythm, 60%,
Oh, man.
which is really high. But remember,
Yeah.
these were just witness
Arrest, you're right.
but still, 60%.
That's crazy.
There was 99% bystander CPR.
Sheesh.
Now, most of that, over 80%, was telephone CPR. The dispatcher says
okay.
push hard, push fast.
Yeah.
But still, 99% bystander CPR.
Pretty good.
The response times, and I'm not a big response time fan, except in this situation. The median response time, 8 minutes. So
Okay.
they're
All right.
getting there fast.
Yeah.
With that in mind, with the biases in favor of ECMO, the trial was stopped early because of futility.
Wow.
Yeah. Let's talk about the results.
Yeah.
They ended up with 124 patients in the ECMO group, 132 in the standard of care. What they found, just to give you an idea about field termination in the ECMO group, you would imagine not a whole lot of field termination, 1%. Standard of care, 34%.
Okay.
So that kind of makes sense.
Yeah.
180-day functional neurologic survival, that was the primary
Okay.
outcome.
I like that.
ECMO, 31.5%. Standard of care, 22%. That is a difference of 9.5% favoring ECMO, but the 95% confidence interval crosses 0. A difference of 0 means there's no difference. So statistically, this was just as likely to have worse outcomes than better outcomes. Now, there is some gold in this lining, if you will. The 30-day functional neurologic survival was 31% in the ECMO group and 18% in the standard of care group. That was a 12% difference, and that was statistically significant. So shorter-term outcome seems to be benefited when you do this. That's really what we have. My takeaway from this is, one, this is a hard study to do. There was some bias because of the crossover in favor of ECMO, yet there still wasn't a benefit. Bottom line. If they had chosen 30-day survival as their primary, then it would have been a positive trial. Overall, the point estimates are really clear. And when the point estimates favor something, but the wide confidence intervals suggest it could go either way, that basically means that maybe this was not powered effectively. And, they did a lot of stats to say, well, we're not going to enroll any additional people, get bigger numbers, because we think even with bigger numbers, we're still not going to see the result. But still, it's a possibility that they would have shown benefit. My big takeaway from this is not that we shouldn't be doing ECMO, but that we need to select the patients better.
Got to be the right people.
Maybe we should only do it in these witnessed arrests that are in VFib and then exclude the patients that are not in VFib. Again, we don't know how they put the Lucas on. Maybe that made a difference.
Yeah.
But bottom line, this is the first randomized controlled ECMO trial I've seen. Benefits are kind of a mixed bag. It looks like there's a trend to good, but the stats say no difference. No difference, at least in long-term survival. So that's kind of the bottom line here. And I think the answer to the question, should you load and go or should you stay and play? I think right now you should stay and play.
Yeah, that's definitely what it seems like, and our experience has been good with that.
Yeah.
So,
And certainly ours has too. I think that's the right thing to do.
do you need lights and sirens though when you go to the hospital?
Oh, baby, that's another podcast. And we're still editing that one.
Right.
It is coming. That's what we got for you from Las Vegas.
Yeah.
Fast 22.
Good to see you guys again.
Yeah. Mikey, welcome back to the pod, man.
Thanks for having me on.
It's great to see you.
Always good to see you. Thanks for having me.
Take care, y'all.
We'll see you.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.